repetition. I'm a strict believer that for things like temporal bone, you have to repeat it like 4 times before you retain it. So intentionally, in the beginning, I will sort of repeat and maybe add to a few points which we did last time. Then I've selected about 10 cases for 10 candidates. Each candidate will be given one case. And the idea is to develop your anatomy, particularly your anatomy of the temporal bone. Of course, most of these cases are exam cases. And I'll tell you when we go through a case that what is the importance and things like that. But some of the cases I've selected just to uh, develop on the concepts of anatomy. And this is what I say, learn anatomy through pathology. So pathologists can teach you anatomy, and some of the selection is for that. So that is the main aim for today. And basically, I'm going to cover this differential diagnosis from your book, Chapman. This is 12.32 middle ear lesions. There is a bit of overlap with some of the differentials like jugular foramen lesion as well as petrous apex, etc. But these are the main things which we are going to cover it. And it will be a good idea to go through all of these uh, after this session. So, case one. Just 1 second, candidate. One, this will be your case. Let me show it on. So, candidate one, can you
Yes, yes, sir, I can hear you.
okay? Can you ask for the mouse, please?
Yes, sir. I requested.
Ask for it again, please.
Yes, sir, I requested.
Unfortunately, I cannot see anything on my screen. Once again,
Yes, sir, I once again um, put a request.
mm, maybe there is a technical issue. Okay, so let's start. I will scroll through it, and I will because the main idea is anatomy. So keep listening. I'm scrolling through it, and then at a particular point, I'll start asking question from you.
Okay,
So
sir.
we are going superiorly. We have gone into the middle cranial fossa, and then we have come down, and we can see the mastoidal cells. What is this structure, candidate one?
This is the mastoid part of the facial nerve.
Of the facial nerve.
Yes.
Okay. Now we are coming inferiorly. We are coming inferiorly. And here, just to orient you, what is this where I'm pointing out?
External auditory canal.
Okay, now you're oriented where we are. So we are have gone up superiorly once again. Which part of the middle ear is this where I'm pointing out?
Uh, Sir, I cannot see your arrow.
Let me, you cannot see my arrow?
Sir, your arrow is right now at external auditory canal on the left side.
I am working through two laptops and I can see my arrow.
Sir, right now your arrow, which is shown to me, is in left external auditory canal right now, and we are in the middle ear cavity image. Yes, now I can see your arrow. These are the middle ear ossicles. You are pointing out at the
Again,
malleus, left ear, middle ear ossicle, malleus.
and which part of middle ear is this?
Uh, Sir, here we are um, in the lateral to medius in the epitympanic recess, and this is here where is arrow right now is cut.
Okay. Now I'm going inferiorly. So here you can see the arrow at the external auditory
Yes,
canal.
yes, sir.
So which part of middle ear is this where I am pointing out? This black space.
Sir, this is inferior part in hypotympanum.
So where is mesotympanum?
Uh, Sir, just below the just below this malleus where
Okay.
we are right now.
Okay. I'm going uh, inferiorly. I'm going inferiorly. Which part of anatomy is this where my mouse is?
Sir,
The straight structure.
sir, I couldn't remember it right now.
Say again, please.
Sir, I couldn't remember right now.
Okay, you
I
cannot remember. Don't worry, don't worry, don't worry. Now, I take you back to the middle ear cavity. Just to orient you, I have gone superiorly. This is the epitympanum, where we can see the head of the malleus and we can see the incus. Now I am coming into the mesotympanum, and here we can see the external auditory canal. So the tympanic membrane must be sitting here. We cannot see it on this bone window. As I'm going inferiorly into the mesotympanum, I can see some soft tissue here, some soft tissue here. And this soft tissue extends posteriorly like this. What do you think is this?
Sir, this soft tissue is most probably in the hypotympanum, and this can uh, this can be cholesteatoma from the pars densa of the tympanic membrane, which is extending to the hypotympanum.
Right. Now, uh, anybody in the chat, do you know what this is? Okay. Somebody has said this is aberrant left internal carotid artery. Okay, candidate one, thank you very much.
Thank you.
So this is aberrant left internal carotid artery with persistent stapedial artery. Uh, First of all, let me go through the case and then we will revise the anatomy. And I have selected this case just as an initial case to develop your concepts of anatomy. Uh, Basically, we will come back to the details, but the relevant portion is look at the carotid canal here. Carotid canal within the temporal bone has got initially, so I've gone into the neck. I'm showing you the normal side. I've gone into the neck. There is a vertical portion here. This is the vertical portion. Then in the petrous apex, it becomes horizontal. So this is the horizontal portion of the internal carotid or the carotid canal. It goes superior to the foramen lacerum, which is known as the lacerum portion, and then it goes into the cavernous sinus. Here is the cavernous sinus. And you can well imagine that it will, with the cavernous sinus, it passes through the cavernous sinus. So we'll come back to this. But on the other hand, what is happening here? What is happening here is that if we go back to the horizontal portion, you can see that there has to be a bone in between the horizontal portion and the medullary cavity. There has to be a bone there, and there is no bone. So it is dehiscent. And this is even on a non-enhanced, you can make this diagnosis, not enhanced CT, that it is projecting into the mesotympanum. And with that, it there is a branch here which is known as the stapedial artery. It goes, this is the stapedius muscle lies here. We'll come back to this part of anatomy. In Usually when a fetus is developing, there is an artery which has got this configuration, and as after birth, it is all obliterated. In this case, there is a persistent stapedial artery, but more importantly, there is an aberrant internal carotid artery. Now, suppose you are a surgeon and you have to do surgery here. So what will happen? If you go in, you might find, a reddish type of tympanic membrane and you think something is happening. And if you go in and you nick it, it will be a disaster. So that is the importance. This particular case presented with pulsatile tinnitus, and this is one of the causes of pulsatile tinnitus. I don't think so. This case per se is an FRCR level case. It is slightly more specialized, so I don't think so. It will be for your exam. Having said that, it is a beautiful case to learn anatomy. So this is where we start. Now, let's go back to a bit of teaching. And there is going to be a uh, bit of uh, repetition from the last session, but you have to repeat it. This is what this session is about. Next session, I've decided that we will take it further and we will go into the base of the skull and PNS and orbit. So that will consolidate whole of this area. If you see here, look at the skull lateral, and this is the temporal bone. The red bone is the temporal bone. Whole of this is the base of skull. The red bone is the temporal bone. I'll come back to the temporal bone. Anteriorly is the sphenoid bone. Here is the occipital bone. Here is the frontal bone, and this is the ethmoid bone. So in next session, we will cover base of skull, all of these things, and there will always be a bit of overlap. Even today, I have intentionally not selected a few cases from temporal bone, which we will do in the base of skull session. Coming back to the temporal bone has got five parts. You don't have to learn, but just to emphasize. Squamous portion of the temporal bone, mastoid portion, tympanic portion, styloid process, and the petrous part of the temporal bone. The squamous portion is where the middle meningeal artery is. Irony is that this is the thinnest bone in the skull. Within the skull, this is the thinnest. And that is why it is prone to trauma and you will develop a epidural hematoma if there is a fracture here. And on the other hand, the petrous part of the temporal bone, which is our main interest, is the most complex anatomy of the human body and which we are going to learn today. And it is a very, very thick bone. So if you see here, it is a pyramidal shape. Let me change my mouse to a laser. So you can see my mouse?
Yes, doctor.
Okay, good. So if you see here, this is the anterior surface, the posterior surface, and the inferior surface. On the superior is an arcuate eminence. Within the temporal bone, there are foramen. So, for example, carotid canal we just did, the carotid internal carotid artery passes through it. This is foramen lacerum. And the case which I showed you, the carotid canal, so the foramen lacerum per se is not a foramen in life. It is there is a some cartilage, etc., sitting there. So the carotid artery passes over it. It does not pass through it. But the portion which passes over it is known as the lateral part. I'll show you a diagram. And this is the cavernous portion. So if you see, this is the pituitary fossa. So you can well imagine that from here to here will be the sitting the cavernous sinus. And you can see that the petrous apex, which is this one, and I'll show you cases today about petrous apex, which are exam cases, is sitting so close to the cavernous sinus here. So coming back to the carotid artery, it passes in through it, then through the cavernous sinus, and then there is a supraclinoid portion. So I was talking about foramen within the petrous temporal bone. So one of them is the carotid artery. Then there are nerves which go in, and the nerves which pass in it are the seventh and eighth nerve. This is the internal auditory meatus, seventh and eighth nerve they pass through. Coming back, please remember this is an anatomy question. If somebody asks you true or false, jugular foramen is a foramen in the temporal bone, and the answer is false. Jugular foramen is a foramen in between the temporal and the occipital bone. This is the jugular foramen. It has got two parts. We'll come back to these, but this is part of our curriculum today. So I'm not going to cover the sphenoid, etc. That is for the next time. Now, if you see here, this portion here where I'm pointing out is the jugular foramen. And look at the shape. It has got two components. Anterior one is known as pars nervosa, and this is pars vascularis. The internal jugular vein passes through this one. So here, the ninth nerve passes anteriorly, and the 10th and 11th pass here. You don't have to remember this, but just to add interest that which nerves pass through it, because then this is in continuity with the carotid sheath within the neck. So these nerves are passing. Key point to remember is that the 12th nerve, which is the hypoglossal nerve, has got separate foramen, which is the hypoglossal foramen. As soon as it passes through, we will learn the anatomy of the hypoglossal canal next time. As soon as it passes into the carotid sheath in the neck, sorry, as soon as it passes into the neck, it goes into the carotid sheath. So it goes with these nerves. And please remember, I'll show you cases where the pathology is sitting here. The pathology is sitting here and the effect is somewhere else. A classical exam case is atrophy of the hemiatrophy of the tongue because this nerve, hypoglossal nerve, supplies the tongue, the intrinsic and the extrinsic muscles of the tongue. So what happens is if there is a lesion sitting here and the hypoglossal is destroyed, there will be atrophy of the hemi-tongue. And that is a FRCR case. I'll show you. So uh, taking it further, if you see here, this is the jugular foramen, and which makes the point that this is the internal jugular vein, which is passing through the foramen. And this is, of course, the transverse sinus and the sigmoid sinus becomes the internal jugular vein. So this is once again the internal jugular vein. Now, carotid artery, once again, if you see here, it is coming from the neck, it passes through the petrous bone. This is the vertical part, and then is the horizontal part. And we saw this horizontal part in this case. Then it passes superior to the foramen lacerum. This is the lacerum part of the internal carotid, and then will be the cavernous portion. So now coming back to uh, coming back to a global view of the middle ear. If you see, this is the middle ear, and we will come back to this in a while. Now, lateral to that is the external ear, and this is the external auditory canal. Superior to that is the middle cranial fossa, the brain. Uh, Medial to that is the internal ear. Inferior to that is the jugular foramen. Inferior to that is the jugular foramen, roughly speaking. And there will be some variations which I'll tell you. Anterior to this, anterior to this is the carotid canal. And posterior to this are the mastoid ear cells. So this is the concept of the middle ear. So first of all, the relations I have covered. Uh, Lateral is the external ear, medial is the inner ear, superior is the middle cranial fossa, the brain, inferior is the jugular foramen, anterior is the carotid canal, and posterior is the mastoid ear cells. So this is the key concept. Now let's go into details. So this is the middle ear cavity. This is the middle ear cavity. And this is the external auditory canal. First of all, the tympanic membrane. So this is the tympanic membrane. There is a bone here by the name of scutum, very important bone, FRCR bone, because this part where I'm pointing out is known as Prozac space. Prozac space is in between the body of the malleus and the head of the body of the incus, which is this one, and the head of the malleus and this bone. This is known as Prozac space. Cholesteatomas, anatomically speaking, are two types within the middle cavity. The most common is known as pars flaccida cholesteatoma. We will come back to that. And one of the things in pars uh, flaccida cholesteatoma is that the scutum, which is thin and sharp and pointed bone, it will be eroded. So you have to tell the examiner that I can see that there is blunting or erosion or amputation of the scutum. That is a key thing. So this scutum is a very important bone. Now, uh, from the scutum, the superior-most portion of the tympanic membrane is attached to the scutum. Inferiorly, it is attached to this annulus. We call it the tympanic annulus. So this is the tympanic membrane. If you draw an imaginary line from the scutum to this thing here, which is the facial nerve canal, tympanic portion. If you draw an imaginary line like this, straight line, from here till the annulus, if you draw another line like this, is the mesotympanum. I'll show you it to you again and again because this concept will be asked in the exam. This is the mesotympanum. Superior to this, which is this one, is the attic or the epitympanum. And inferiorly, this trough like, which has got nothing there, will be known as hypotympanum. So this is a global view of the middle ear. If you see superiorly, there is a bone here which is known as tegmen tympani, and superior to that is the brain. And this bone becomes FRCR bone because you will be, they will show you cases in which it is eroded, and you have to tell the examiner that this is eroded. So scutum has got importance. This tegmen tympani has got importance. Another importance is of this structure here. What is this structure? This structure is the inner ear, and this is the vestibule, and this is the superior semicircular canal. This is the lateral semicircular canal. Lateral semicircular canal is an exam canal. Remember that because it is projecting here. There is bone here, and it is projecting and touching the in between the canal and the middle ear cavity is a bone, and this is normal. They will show you cases in which a cholesteatoma will be sitting here and will be causing fistulization of the lateral semicircular canal. So these are the key 3 points which you have to remember for your exam vis-a-vis any erosions, etc. Coming back to the ossicles. So we have got 3 ossicles, and portion of them are in the mesotympanum and portion of them are in the epitympanum. This portion of the malleus is attached to the tympanic membrane. Then it goes superiorly, the neck goes superiorly, and the head is sitting in the epitympanum. Second bone is the incus. Incus has got a body. This is the body, this is the short process, and this is the large process. Please remember that the body and incus and the short process, sorry, are sitting within the epitympanum. But the long process, it dips down back into the mesotympanum and makes this joint with the stapes. This joint is again an exam joint. Remember this. This is the head of the malleus and this is the incus. This joint is incudo-malleolar joint. Incudo-malleolar joint. And they will show you trauma cases, brain trauma cases, in which there is dislocation of these joints. This joint is known as incudostapedial joint. And by the way, in real life, we can actually pick up dislocation of this joint. But in the FRCR, they are not going to show you, it's too much. But this one you can see in NECT. This bone is the smallest bone of the human body, and it is known as stapes. Stapes joins the oval window of the cochlea. This structure here is the anterior crus, and this is the posterior crus. This is about 0.58 millimeter in thickness, and interestingly, on the present era CT scans, we can see it because the slice is 0.62. So, once again, this is portion of the malleus which is attached to the tympanic membrane. Then the head goes into the epitympanum, and then this is the body of the incus, short process, the long process, incudo, stapedial joint, anterior process, posterior process, and this is the foot plate which is on the oval window of the cochlea. This is the internal ear. Luckily, it is beyond FRCR. So I'm not going to teach you in great detail. That is an FRCR exam is what we call a general radiology exam, and there is they don't expect subspecialty type of things, congenital abnormalities and everything. So, but you should have a general idea that this is cochlea and how cochlea looks like on a CT scan, and this is the vestibule, which is made up of utricle and saccule. This is the superior semicircular canal, the lateral semicircular canal, and the posterior semicircular canal. So this is what we call membranous labyrinth. There is a, the terminology is there is a bony labyrinth and there is a membranous labyrinth. The bony labyrinth is very well seen on a CT scan, and anything which has got fluid inside is the membranous labyrinth, which is seen on MR. So we are not going to go into the details of endolymphatic duct or perilymphatic duct and endolymphatic sac, etc. Uh, One thing which I always tell students that endolymphatic sac, this thing, just remember that it sits on the posterior wall of the petrous pyramid. There is one tumor, which is endolymphatic sac tumor, which can occur with VHL, von Hippel-Lindau syndrome. And radiologically speaking, it will be ugly, it will have enhancing features, it will have destruction, but it's a very rare, very, very rare tumor. So as far as my knowledge goes, nobody has asked it in the exam, but just remember that there is a tumor. I don't teach it actually, but there is a tumor which arises from endolymphatic sac, and that is in VHL. So suppose you have got a long case, etc., where you have got other stigmata of von Hippel-Lindau in the body, and temporal loan lesion is given, it might be an endolymphatic sac tumor. So I always teach um temporal bone vis-a-vis the facial nerve because it passes through it, it courses through it. This is the schematic diagram on which we will make our concepts. So this is the seventh nerve it arises from the pons, it passes into the internal auditory meatus, then goes into the bone. This portion is known as labyrinthine portion. This is the anterior genu and this is the posterior genu. Here is a ganglion, which is the geniculate ganglion. From the geniculate ganglion arises a nerve which you don't have to worry about, but this is the greater superficial petrosal nerve. It makes a plexus here, pterygopalatine plexus with other branches of fifth nerve. And this is responsible for lacrimation, submandibular, lacrimal gland, and parasympathetic supply, lacrimation as well as parasympathetic supply of sublingual and submandibular. Now, coming back, uh, so we are not worried about, but this concept should be known to you. But this, from the geniculate ganglion, the facial nerve turns 90-degree backwards, and this portion is known as tympanic portion. And this portion is very well seen on a CT scan, and I'll show you. And then it goes posteriorly, and then it goes vertically down. Where it goes vertically down, this is known as the mastoid portion of the facial nerve. It passes through the stylomastoid foramen and then goes into the parotid gland. At the parotid gland, it will give its terminal branches. So this diagram tells you the same thing once again. So this is the within the CP angle cistern. This is the labyrinthine portion. This is the geniculate ganglion. This is the tympanic portion. This is the mastoid portion. This is the stylomastoid foramen. Next to it is the parotid gland, and here it divides into its terminal branches. Another branch which is highlighted here, which you should know that the descending portion, there is a muscle here, which is the stapedius muscle. Stapedius muscle. The nerve is there is a branch here which supplies it. And remember the case one which we show was aberrant, persistent stapedial artery, which was supplying this part. As it goes down, there is another important branch which comes out. This is the cauda tympani. Cauda tympani actually is responsible for anterior two-third taste from, so it supplies the taste from anterior two-third of the tongue. On an axial, now concentrate on this axial because we are going to see the same thing on CT scan. This is the pons. From the pons, two nerves are coming out and they go together, sort of imaging wise, they go together. One is the vestibulocochlear nerve, vestibulocochlear. So there is one component which comes from the cochlea, which is the cochlear nerve, and there are two nerves which come from the vestibule. These are known as superior and inferior vestibular nerves. So two nerves are coming here and one nerve is coming here. They join here and that will be the vestibulocochlear nerve, eighth nerve. But just superior to that, just superior to the level of the cochlea is the seventh nerve. This is the seventh nerve on an axial slice. As soon as it enters the bone, this is the bony part. This is known as the labyrinthine part. This is the geniculate ganglion. It passes posteriorly, and this is the tympanic portion. And then it will descend down. And as is seen on this diagram, it descends down like this. So this portion, this nerve is the greater superficial petrosal nerve. We can see this very well here. The labyrinthine portion is visible here. This is the geniculate ganglion. One point which I forgot to tell you, one landmark is that this is the lateral semicircular canal and the facial nerve passes below it. Remember that in the medial wall of the middle ear. So this is the middle ear. And if you see here, this is the geniculate ganglion. It will pass. Now, this structure here is the lateral semicircular canal, and this will become clear when I'll show you on a DICOM image. It passes posteriorly like this, inferior to this. This is the facial nerve canal. And on a sagittal also, you can see that it passes like this. We call it the hockey stick appearance. The coda tympani can be seen on imaging. It arises and passes anteriorly. It is responsible for taste from anterior two-third of tongue. So on an MR cis sequence on a sagittal oblique, you should have clear-cut concepts that you will see four nerves. So orientation wise, this is the cerebellum, this is the anterior, this is the posterior. Here you can see four nerves, and the formula is 7 up, coke down. The seventh nerve, which is superior to the cochlea, is this one. This is the cochlear nerve, which is here anteriorly, superior vestibular, inferior vestibular. And I told you last time also that one of my registrars, she got this in the exam. Actually the examiner opened it here, sagittal oblique. So this was this first sequence, and the questions were about anatomy. So you should know this, that on a cis sequence, how it shows. Now, once again, repetition of the room concept of middle ear. Now, concentrate what is in which, this is the middle portion, which is the mesotympanum. If you draw a line, this is the tympanic membrane. If you draw a line superior at the superior edge and passes through the facial nerve canal on the medial wall, inferior to that, and another line which you draw at the edge of the tympanic membrane, the annulus. This will be the mesotympanum. Hypotympanum is just a trough which has got nothing more than that, inferior to that. Within the mesotympanum, we can see that part of the ossicles are there. Then on the medial wall, this is what we call the promontory of the cochlea. This is the stapedius muscle, and the oval window will be here. This is the lateral semicircular canal, and inferior to that is the facial nerve canal. Now, posteriorly, if you look posteriorly, before we go posteriorly, we go superiorly. So this portion superior to that is the attic or the epitympanum, where the head of malleus and the incus is. And this bone is the tegmen tympani, which is in between the middle ear and the brain. Now, posteriorly, there is an opening here which is known as editus ad antrum, because on the other side is the mastoid antrum and then the mastoid ear cells. So, once again, I told you the walls, the lateral wall of the middle ear is external auditory canal or the external ear. The medial wall is the internal ear. The superior wall is the tegmen tympani. The inferior wall below that is the jugular foramen. Anteriorly, there will be carotid canal. Posteriorly, there will be mastoid antrum and mastoid ear cells. So this is once again a repetition. This is the medial wall. You can see the promontory here. You can see the facial nerve. You can see the lateral semicircular canal. This is the medial side. This is the tympanic membrane, and this is the epitympanum, where you can see head of malleus and the incus, and this is the incudo-malleolar joint. And this is the short process. This is the body. This is the short process, and this is the long process. This is, of course, the chorda tympani and the correction. This is the chorda tympani, and this is the descending portion. Okay, now just concentrate on the facial nerve on this. So if you see here, this structure here is the orientation wise. This is the internal auditory meatus, and the nerve which is now I am going inferiorly. As I go inferiorly is the cochlea. This flower-like structure, I call it the flower. The flower is the cochlea, and this is the internal auditory canal. So orient yourself by this. Go superior to the cochlea. Just go superior. I'm going superiorly. As I'm going superiorly, we can see this structure here. This is the labyrinthine portion of the facial nerve. It goes anteriorly, the geniculate ganglion, and on here, this is the lateral semicircular canal. This is the lateral. You can see it makes this circle. And lateral to the lateral semicircular canal is the middle ear. So coming back, please remember we are learning through the facial nerve. So the facial nerve, this is the tympanic portion where the arrow is, and you can see it becomes a straight line. I'll go up. So this is the lateral semicircular canal, and you can see how it is passing on this axial below the lateral semicircular canal till the time it reaches the mastoid, the posterior genome. Here, if you look carefully, you can see the stapes here, and there are other structures which I'll point out in another series of diagrams. But right now, just concentrate on the facial nerve. So now I am going to go down. I'm going down inferiorly. It goes down, 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 and it goes ultimately through the stylomastoid foramen outside the temporal bone. You stretch of imagination, you can see that the mandible is sitting here. You can imagine that the parotid gland is here. So it goes into the parotid gland and divides into branches. So with this concept of facial nerve on axial, let's see the facial nerve on a coronal. Now, on a coronal, we can see this is the cochlea. This is the cochlea. And I'm going into the internal auditory meatus. So this is the internal auditory meatus. You can see this is the labyrinthine portion where the arrow is. Now I stop here. And this is what can come in your anatomy exam also. And the examiners can also ask. There are two dots here, one dot here, one dot here. This is owl eye appearance. And this is the labyrinthine portion, and this is the tympanic portion of the facial nerve. Let me trace it. So I come back. So from the internal auditory canal, the labyrinthine portion, this is the labyrinthine portion. This is the medial eye. This is the lateral eye. It goes anteriorly, and here is the geniculate ganglion. And from there, it turns 90-degree backwards, and this dot here is the tympanic portion. Please remember the landmark. It passes below the lateral semicircular canal. So it is passing below, it goes posteriorly, it goes to the mastoid portion, and then it descends down like this. This is the stylomastoid foramen. So now, and just a quick one, on a sagittal, the descending portion is very well seen. So this is the descending portion. We call it the hockey uh, stick appearance. And actually, you can see here where I'm pointing out the chorda tympani actually arising from it. So this is the descending portion. On a sagittal also, you will see it very well. Now, uh, let's go to a more global view of the temporal bone. So we have just concentrated on the facial now, right? Now let's have a global view, because in the exam you should have this kind of a view where this is the mastoidea cells, the mandible is sitting here, and here is the clivus, and this is the mastoidea cells. Then as we go superiorly, now this is the jugular foramen. You can see the jugular foramen here. And in this particular case, the petrous apex is pneumotized. Please remember that can happen. So there are air cells, just like here, there are air cells here. Actually, on the right side, there are more. So this is just normal variation. As a landmark, this is the external auditory canal. Anterior to that is the TMJ, and this becomes a FRCR, your checklist, because they will show you trauma cases in which this thing will not be sitting where it should be sitting. And on an axial sequence, you should raise the issue that it is dislocated. So coming back, now if you see this is the external auditory canal, you can actually see a thin line here. Maybe it is projecting for you or not, I am not sure. But having said that, if you change your window, you can easily see it. Here, anterior to that is the carotid canal. So this is the carotid canal. Carotid canal, the vertical portion, and then the horizontal portion. And then, of course, here is the cavernous portion where I am pointing out. Coming back to the middle ear. So this is the external auditory canal. This is the tympanic membrane. This space is the middle ear cavity. And then we can see these ossicles. Actually, this is the stapes. And you can see this semicircular canal where I'm pointing out. You can see this facial nerve canal. So this is the mesotympanum. This is the mesotympanum. Sorry, I go back. So this is the mesotympanum where the external auditory canal is coming. 3 points here, which on the posterior wall of the mesotympanum, you can see this pyramid where I'm pointing out. The facial nerve is sitting here. This is known as pyramidal eminence. And this is the facial sinus tympani and the facial nerve recess. You don't have to remember this bit. Uh, and the stapedius muscle will be sitting here. But the key landmark on the axial is the epitympanum. So this should be etched in your memory, this image. This is the epitympanum. Here, the head of Malleus and the body of Incus and the short process. You can see that there is an hourglass appearance. Hourglass appearance. There is anterior widening, then there is constriction, and then there is widening. So this is the epitympanum. This is the additus ad antrum. Additus ad antrum. And then is the mastoid antrum. they will show you cholesteatoma cases in the exam where this thing might be expanded, and that will what the examiner asks. So beware of that. So on a coronal, uh, I'm now showing you the global perspective. This is these are the mastoid hair cells. The bone superior to the mastoid hair cells, and which is the middle cranial fossa is here. This bone is known as tegmen mastoideum. Tegmen mastoideum, because they will show you cases in which it will be eroded. On the other hand, this bone, which is superior to the middle ear, it is tegmen tympani. Tegmen tympani. So tegmen mastoideum, where mastoidal cells are there. I'm going anteriorly, and this one is tegmen tympani. Now, so once again, you know that these owls are the facial nerve, etc. And now our interest is on other structures. So this is the cochlea, and this is the vestibule. This is the superior semicircular canal, and correction, this is the superior, and this is the lateral semicircular canal. So, and inferior to this is the jugular foramen. So, with this, uh, this is the MR, and on MR, this is, this flower. Flower is the cochlea, and the cochlear nerve is coming out in green, just superior to the level. Now I'm going superior to the level of the cochlea. So this nerve is the eighth nerve, vestibulocochlear. Now you can see another nerve coming out, and this is superior to the level of the cochlea. So this is the facial nerve, and the bony part of it is better seen on a CT. Otherwise, this part is better seen on an MRI. In the chat, this is the same quiz which we did last time. So anatomy part or the lecture part of it is finished, because now I'm going to show you 9 more cases after this. Now, do you want to repeat this quiz? It will take how many minutes? 34 and 4. I think 10 minutes or so. Do you want to do it? In the chat, tell me. This is a repetition. There is nothing new, but repetition is very important for you. There are quite a few no's and there are few yeses. So we what we'll do is I'll do a hybrid model. I'll not go for I'll not ask you. I'll just repeat what is written there. So we are not going to go through the quiz. I'm just going to repeat it. So this is the external auditory canal. This is the petrous apex, and part of it is nemotized here. And of course, this is the clivus, and this is the carotid canal. This is the jugular foramen. And the middle ear cavity is coming into view. This is the TMJ. Here we can see external auditory canal, the middle ear, sorry, this middle ear cavity, mastoid hair cells, and of course, this is clivus, and this is the petrous apex. So please remember that this part of anatomy, the clivus, is technically the sphenoid bone, and a portion of it is sphenoid, and portion of it is occipital bone. But petrous apex is sitting here. And next cut here, we can see mastoid hair cells, we can see stapes, we can see the cochlea, we can see the vestibule, and we can see the facial nerve. Here we can see head of the malleus uh, and the body. This is the encodomalleolar joint. This is the Prozac space, which is extremely important, because if you see a cholesteatoma sitting here, you have to tell the examiner that it is sitting in the Prozac space. This is portion of the lateral semicircular canal. This is the facial nerve canal, which is sitting internal auditory canal. This is on a coronal. On a coronal, you can see these owls, labyrinthine portion, and the tympanic portion, owl eye. And this is the scutum. This is the cochlea, and this is the head of the malleus. This bone is very important. This is the scutum. And this is again the Prozac space. This is the scutum. The owl eyes are still visible. This is the tympanic portion. This is the labyrinthine portion. And here we can see the superior semicircular canal, the lateral semicircular canal, and the facial nerve canal is inferior to the lateral semicircular canal. This is the lateral semicircular canal. And inferior to that is the facial nerve canal and the vestibule. And this is the descending portion, which is the stylomastoid foramen, and this is the descending portion. On a sagittal, we can see the same thing. Now, before I start with the cases, two cases which I am not showing you right now, but I am just on PowerPoint, I will, to develop your anatomy concepts, I will show you. So one of the case is, this is what I was talking about. This is the normal incudomalleolar joint. And this should be your checklist in a trauma case. They will show it to you on a brain trauma case. And this is an example where you can see that on this cut, you can see that this is what we call ice cream cone sign. And it is not sitting, the cone is not sitting, correction, the ice cream is not sitting on the cone. So this should be in your checklist. Another example where you can see that this is the cone and there is air in between, so there is dislocation of the two. Another thing which I wanted to, I'm not going to show you this case. I believe this is slightly beyond FRCR level, but I'm going to show you in a PowerPoint mode just to develop your concepts and of course your day-to-day reporting. Perineural tumor spread around cranial nerve 7, most commonly seen with adenoid cystic carcinoma of the parotid, ill-defined enhancing tubular lesion extending from the parotid tumor through stylomastoid foramen, and ultimately it goes into the brain. This concept is important for you. If you see here, this is the parotid gland. If there is a tumor sitting here, it goes, this is known as perineural spread of the tumor. It goes through the stylomastoid along the facial nerve. The facial nerve, as if it is fire, it goes along a wire. And from here, it can go all the way into the cranial cavity. Same concept. This concept is an exam concept. This one is slightly beyond exam, but this one has been asked in the exam because the foramen here is bigger. And here, uh, if you see there can be masticator space lesions which can pass through the foramen and then go into the cavernous sinus, etc., etc. Base of skull, we'll cover it next time. So this is the facial nerve, and I told you that portion of the facial nerve, the greater superficial petrosal nerve, produces a ganglion here with branches of fifth nerve. So I'm showing you a case from our collection in which what happened was that the patient presented quite a few times with symptoms, but appropriate imaging was not done. And in lower motor neuron lesions, when you are worried about lower motor neurons of the facial nerve, please remember that it goes beyond you cannot just do brain imaging and sit on it, because the lesion might be in the temporal bone or it might be in the parotid. So that's the key learning point. In this case, from the deep lobe of the parotid, there was a adenoid cystic carcinoma sitting there. And these scans were brain scans. Actually, they are not classical high resolution fat saturated for temporal bone. But here you can actually see, if you look carefully, you can see this dot where I am pointing out. This dot is the enhancing portion of the facial nerve, the descending, the mastoid portion. But what happened now here, you can see where, here you can see that the tympanic portion is also enhancing. But more importantly, you can see that there is a lot of enhancement in the internal auditory meatus. So this is perineural spread. In this case, what had happened is that because of the pterygopalatine ganglion, tumor went there, and then through the branches of the trigeminal nerve, it pass into the cavernous sinus. You can see portion of it here. So there was perineural spread along the seventh nerve as well as the fifth nerve. So this is the fifth nerve, and you can see it here on how it is going superiorly. So this tells you the concepts of perineural spread. Okay, now we start with the cases. So, candidate 2, let me Candidate 2, are you with us?
Yes, I am.
Okay, so candidate 2, okay, this is your case. Let me give you the history.
Hmm.
This is a 70-year-old left-sided periauricular swelling and tenderness, pus plus plus external diabetic patient. Over to you.
Um, can I scroll or I'm on iPad. I don't know if I can scroll.
You have to ask for the mouse.
Right.
Anybody who volunteers to be a candidate should learn how to ask for a mouse.
Sorry, I thought it's not possible from an iPad. Tools.
Okay, I'll scroll for you.
Okay,
Now,
thank
the
you.
patient has, we are our, swelling, tenderness, pus discharge from left ear, diabetic patient. So, uh,
Yes, so I can see an axial CT on a bony window. What caught up my eye immediately is soft tissue swelling over the left, um, possibly cheek area, and over the external auditory canal, with a bit of widening of the external auditory canal actually, and some bone destruction and lucency. Um, around it. I can see the ossicles um, on the left temporal bones. So the inflammatory or infective process is not has not eroded into the middle ear. So on this slide specifically, I can see that there is quite a significant bony destruction um, of the mastoid air cells, and there's fullness of the mastoid air cells, and there is destruction. These coronal. Um, on the coronal, on a separate note as well, there's degenerative changes of C2 dense, sorry, C2 odontoid peg. And again, I can see the destruction, um, the bony destruction and the widening of the external auditory canal on the left. There is also fullness of the mastoid air cells. I think on the top of my differential, I would first like to look at the same images on the soft tissue window to see the extent of the soft tissue. Yes, so on the soft tissue window, I can see that there is heterogeneous appearance and swelling um, over the left cheek, and there's also um, heterogeneous appearance and fullness of the external auditory canal with the soft tissue material. There's also a bit of gas, I think. No, not really. It's probably, well, there is a bit of locules of gas as well. And this is extending up to the left temporal bone, or sorry, to the left temporal subcutaneous tissue and soft tissue area. Um, Again, there's features of this destructive soft tissue mass to the bone and to the distorting the anatomy in the left
So what?
temporal bone.
Conclude.
So I think on like trying to list my differential. So because the patient is diabetic, this could be like a fulminant otitis externa or a malignant otitis externa that is forming all this abscess and soft tissue destruction and extending into the ear. Um, Another differential would be a malignant process, but with the history of diabetes and also with hello.
Yeah, I said thank you.
All right. Okay. Sorry.
So this is malignant otitis externa. Now, candidate two, why did you go into the world of malignancy when you did it so well?
I think I felt pressure to say something else, like to say. So I was going to go against myself and say I don't think it is malignancy because the patient is diabetic. It looks very much like an infection and abscess formation with bony destruction. So I think I would go first. I would first go for malignant otitis externa.
Okay, so you were trying to just discuss it and rule it out. This is what you were telling us.
Yes.
Okay, well done. That
Thank you
was
very much.
well done. So this was a simple case. This is what we call malignant otitis externa. And this patient, unfortunately, for other reasons, did not survive that day, and uh, we lost her because we had asked for initially a CT with contrast, but the patient became unwell and they, heart, etc. So I don't have another scan to show you. Having said that, this is malignant otitis externa. Now, in here, what we see is that the candidate did very well. If you see even on the bone window, so this is what the exam is about. Keep your minds open and then you can ask for a soft tissue window. The candidate did very well. where she said, I would like to see a soft tissue window. Please remember in head and neck radiology, and this is true for paranasal sinuses also, it should be your routine that though routine scans are not done with contrast, you must see the soft tissue window. And they will show you cases there. And then it is legitimate to ask for a contrast or MR, whatever the scenario is. So she did very well because she pointed out that she asked for that window. So I like that. Now, if you see, look at the destruction, it's horrible. And everything is gone. And you can see even look at this TMJ where there are a lot of erosions, etc. We'll come back to the sagittal. Uh, sorry, the corona. We can see opacification of the mastoid air cells and the middle ear cavity. Candidate 2, I think in your hurry you use some other word for I don't think so. You said opacification of the mastoid air cells. What did you say about the mastoid air cells?
So I wanted to point out that it is filled with fluid rather than air, so it's not aerated anymore. So
You use
maybe I should have used a
opaque.
different, yeah.
That's use the word opaque, opacity, right? This is
Okay.
this. So use that word. There is a soft tissue opacity in the mastoid air cells, or they are opaque. That is how you in temporal bone or paranasal sinuses. This is the word which you use. So
Mm.
and then the middle ear, the pertinent uh, negatives will be that is there any middle ear or any mastoid ear cell destruction, as in the mastoid. Now this is the mastoid tegmentum mastoideum, which is fine, and this is the middle ear cavity. So the opacity is there, but tegment tympani is fine. The ossicles are fine. So in head and neck, the main thing is what is the epicenter of the lesion. And you can see that this is external auditory canal, which is gone. And this is also completely opaque. Compare it from this side. But the epicenter is the external auditory canal. So this is what we call the malignant otitis externa or whatever. So it was well done by the candidate. Okay,
Thank you very much.
good. Next candidate, please.
Yes, I'm here.
So
My
your case. Let me give you the history.
yes, please.
This is 6-year-old, and the patient is 6-year-old crying pain in the ear, A&E case. From the A&E, the patient came in.
Patient crying from pain in the ear.
6 years old child, very unwell, fever, pain in the ear. Over to you. Left ear.
So I can scroll, please.
Yes, you can. I think I've given you, yes.
So I've presented with uh, uh, bone window, plain CT without contrast, so that's showing
Temporal bone, please. Temporal bone.
temporal bone. It's okay. So I have ossified paranasal sinuses, both maxillary and osmoidal air cells, and also there is air loculi is presented as anterior temporal space intracranial, and there is another soft tissue at the edatus and antrum. Also complete ossification of middle ear cavity, and there is epiphysin at the mastoid antrum. Also there is sclerosis of left petrous bone and mastoid air cells. Um, there is mild obstruction of the thickness of the tympanic membrane and the retraction. Could be automastoiditis and complicated with intracranial extension of air. I need to show if there is a coronal study to show coronal imaging to assess the tegment tympani and the tegment mastoid, and if there is contrast study to assess the venous deep venous system and the sinus.
Just 1 second, please. I've given you coronal.
Okay. So I have scrolling coronal view. The temporomandibular joint is unremarkable. There is no dislocation or subluxation. I have presented with also the external auditory canal, and there is obfuscation of middle ear cavity, and the tegment tympani looks there is erosion or wide thinning and probable erosion. There is ear loculi seen here and non-dependent, and the tegment of an eye looks like interrupted, or there is erosion or destruction of tegment tympani plate. So this is maybe the patient presentation could be consistent with automastoiditis complicating intracranial extension. Okay, the soft tissue window, that there is epidural collection, and there is air foci seen non-dependent could represent epidural empyema. Uh, so if there is contrast, I will contrast study. I will
So,
show if there is the enhancement or the diffusion restriction. I will see if there is diffusion restriction to differentiate simple collection from empyema.
okay, thank you. So this was acute mastoiditis with epidural abscess. I'll come back to the case shortly. And this is from your book, Acute Mastoiditis with Abscess. So clinical, of course, is very important. You have to look for any, of course, the opacified mastoidea cells, cortical or trabecular erosions. The candidate did well, where the candidate was looking for any dehiscence, and at places, some suspicion was raised, and there were minor, erosions and cortical dehiscence. And there was a brain abscess. And with that, always, so again, candidate did well, where was worried about other things happening and asked for next exam, which I'll show you. So please remember, in head and neck, most important for FRCR are complications of infections, may it be for paranasal sinuses or temporal bone or whatever. So, and because these are the types of patients which present in the A&E, and and this is what the examiners are after. So they want to see that you are a safe radiologist, even if you are not a classical subspecialty head and neck radiologist. You can pick up these things. Any radiologist must pick up these things, any radiologist. And this is what FRCR exam is about. Now, in this particular case, uh, though I have not given you bone window, but you can see this destruction happening. And with that, there is a, if you see here, there is a soft tissue abscess. With that, if you see the jugular vein, there is a filling defect in the jugular vein, the sigmoid sinus filling defect, and the transverse sinus filling defect. So again and again and again, these cases come, and it all depends which modality they are showing to you. Similar to the case which I showed you right now, look at this one, another one, in which we can see that there is opacification of the mastoidea cells, and there is an air bubble sitting in the middle cranial fossa, and there is opacification here, and you can see that there is dehiscence of the bone here. So it is quite similar to the one which we saw, but the dehiscence is more pronounced. In this particular case, these words, when I show you an MR, though I did not show an MR to the candidate, but if I show you an MR, you have to see for any meningeal enhancement, mention that. You have to see the brain parenchyma. If the brain parenchyma is abnormal without any abscess formation, we use the word, cerebritis, which is a journal term. that infection is going in. Uh, if there is an abscess, then call it abscess. Always look for venous sinuses. Of course, in this case, we already know that there is a dural venous sinus thrombosis, but we can see that there is meningeal enhancement, and we can see that there is cerebritis. So now let me go through the case. Uh, Candidate 3, one thing, just like the previous candidate, you should have asked for a plain, soft tissue window, right?
Yeah.
So, and you can see it's though you had picked up the finding, but you are more confident that there is an abscess. So, as a rule, ask for soft tissue window, and then you did everything else was fine. Now, in this particular case, we can see that this is the external auditory canal. As we come here, there is opacification of the middle ear. It is completely opacified as I go uh, superiorly, and you can see that the tegmen, sorry, the epitympanum is also opacified. This is the editous odontrum, this is opacified. Mastoid antrum, opacified, and maybe just a bit of air is there, and this might be cause of infection. Most of the mastoid air cells, they are opacified with just a few air bubbles. Coronal is a good one. You have to ask for coronal so that, is erosions, etc. Particularly, you will see very well. So, of course, we knew that there is an air bubble. And here, the candidate did well, where was mentioning uh, suspicion of bit of. So here the bone is thin. These are, we are in the mastoid air cells, and one can see, I don't know if it is projecting for you very well, but I think one can convince that there are subtle dehiscences, particularly here where I'm pointing out. As so there is some sort of, so, and even if the examiner show you this case, they will ask you anatomy questions. What is this? What is this? What is that? And the only thing is that on a soft tissue window, though this is a bone algorithm, but even then we can see the abscess very well. So this is an abscess. So I've got an MR of the same patient, but this MR was done 4 days after. So that is why I did not show to the candidate. 4 days after, if you see here, that mastoid air cells are all full of fluid. You can see the same thing. And here anteriorly, the abscess looks slightly less. You can see this is epidural, this is extra axial, and you can see this air bubble, and this is the air fluid level here. So the abscess has reduced slightly, and so on a flare sequence, it is not as clearly seen, but the main thing is it is extra axial, epidural. And we have got a contrast, which is here. And now you can see that it is sitting outside. You can see this meningeal enhancement, and this is leptomeningeal enhancement, and you can see that the enhancement goes inside. So this is the pia mater. So this enhancement, otherwise there was no extension into the brain parenchyma. So meninges are, and you compare this meninges with this one, and you can see it is enhanced. Okay, candidate 3, well done. Candidate 4, are you with us? Are you unmuted, candidate 4? I cannot hear you. Let me check. candidate for. I've lost you. Are you there? Yeah, you are there. I can see you. Make co-host. Can you unmute yourself, candidate?
Yes, sir, I am here, sir.
Okay. Now concentrate on the right temporal bone. And I warn you, there is a bit of fine touch in this case. So everybody, please see it very carefully. It's a good one. Till now, I have shown you slightly simple cases. This one requires a bit of anatomy. So this is 84-year-old, right-sided chronic mastoiditis. Rule out a cholesteatoma. This is what they have written.
Okay, sir. I'm provided with the cone view HRCT of the temporal bone. And
Shift it here. Okay, please continue.
okay, sir. Okay, sir. I'm scrolling, and I can appreciate that there is a loss of aeration in the right-sided mastoid air cells, along with the destruction of the mastoid air cells is noted. And then as I scroll down, okay, so there is opacification of the middle ear cavity is also noted, and the ossicles are not clearly visualized. And then so there are erosive changes noted in the region of the mastoid as well. I would like to review it in the coronal window to look out the blunting of the sputum, and also to look for the tegment tympani. And now, as I am scrolling upward, there is also loss of the aeration in the uh, petrous apex also seen. The internal auditory structure, which include cochlea, vestibule, and the semicircular canals, are grossly unremarkable. Sir, I need coronal section to.
Okay, you have said initially in your description when you were describing the mastoid air cells, you said that there is destruction also. Where is the destruction? Point it out to me in the mastoid air cells. This is where you started, right? Your description.
Yes, sir. Yes, sir.
Where is it?
Sir, if compared to the left, there is loss of the mastoid cells. So, sir,
You use the word destruction. So where is the
yes. Uh, Sir, this loss of variation pattern, and sir, there is opacification. I think I
you
overcalled it as destruction.
correct that?
Yes, sir, I overcalled the word destruction. So there is loss of aeration and opacification.
Questions? Now, where point out the middle ear cavity to me here. Point out,
This is the left, and on the right, this is the middle ear cavity, and I cannot see ossicles here, and there is soft tissue, there is opacification.
point out the mesotympanum to me.
Okay, sir. Sir, if I go below the ossicular level, so this is the mesotympanum, and if I go above it, sir, this is the epitympanum.
Okay, now we go to the coronal. You were asking for a
Yes,
coronal.
sir, coronal. Sir, on the coronal, sir, I would like to. Okay, sir, there is. Sir, can you just fix it so I can see the contralateral side as well? I am unable to see the
Uh,
compare for the comparison.
I'm just showing you a single, and usually in some departments they just send right temporal
Okay,
side,
okay,
left.
sir. Sir, there is blunting of the scutum noted, and the sharp blunted end of the scutum cannot be seen. And also, sir, the tegment tympani shows. So I would, sir, there's thinning of the tegment tympani noted. So I'm, sir, concerning for cholesteatoma formation, and I
Point
can
out,
advise MRI with diffusion weighted images to confirm my findings. If there is restricted diffusion in this area, then, sir, this is diagnostic for cholesteatoma.
point out the scutum to me.
Sir, the medial most part of the external auditory canal, sir, this one is the scutum, and sir, this blunting of the scutum,
Just with an arrow, point out where is the
sir,
scoop.
this one.
Why are you saying that there is a cholesteatoma? Where is the cholesteatoma? Which part of the ear, middle ear, is the cholesteatoma?
Sir, this is the Prusak space, and then soft tissue or in the Prusak space, and then along with this, there is blunting and loss of the sharpness of scutum. Sir, that's why.
Where is the mesotympanum?
Sir, mesotympanum is above the sir. This one is the epitympanum, and this is the mesotympanum.
Where is the lateral semicircular canal?
Sir, lateral semicircular canal. So, so this letter says,
Show me the labyrinthine portion of the facial nerve canal.
okay, sir. Sir, this is the labyrinthine and this is the tympanica.
Is it normal?
Sir, sir, the tympanic portion is not normal. And sir,
So, thank you. So, what was your conclusion? Was a
sir,
pars, is it
cholecystoma.
placida or pars tensa cholesteatoma?
Yes, sir, pars placida. Sir, pars placida.
Okay, thank you. Okay, now listen very carefully a few slides about cholesteatoma. Now, if you ask me that other than infection, which is the most important part, actually, sorry, this is not a, there's a typo here uh, on the slide which I am showing you. So the correct thing is that this is